Duncan, our next presenter has done presentations for us a couple of times now and has put together a simulation lab in Queensland. And Duncan, we're excited to hear about the advances that you've made in simulation. Did you want to lapel mic or?
Yeah, why not? I'm not good at standing still.
Doug, did you have the lapel mic? Did you use the lapel mic? Susan? Yeah. So down is next slide. Yeah. Up is previous slide. Yeah. The one in the middle is pointer. And we'll have a lapel mic here in just a second.
Good. Yep, no worries. Hi everyone. My name's Duncan McConnell. I am from Australia. So today you've got a few Australians talking today. You'll probably see on some of our slides, a few of us have our cuddly koala. So I do apologise in advance if you get bamboozled by koalas. Okay, whoop, wrong way already. Good start. Okay, so there's a classic picture that was put up already by Neil Kirby. I didn't forget Tasmania, it is right down there on the corner. I'll just point it out just in case, because it is small. There it is. And over here somewhere is New Zealand. Yeah. So a little bit about Australia. We're one of the few countries where you get off an aeroplane and you're greeted with warning signs saying we have animals that will eat you. Okay? That one's out of Cairns. But we have people like that look after our crocodiles. And we've also got some national icons. So, being in Queensland, some of our national icons are a little bit more ferocious than others. So we have the drop bears. So it's like a really ravaging koala bear. No, they don't exist, just in case anyone thinks that they do. It's sort of a trick we play to our overseas visitors. But some of our other national icons that help deal with that are people like our own Wolverine. So back onto the more serious side of stuff, we're located, well my particular university is located on the beautiful Gold Coast. That's the home of the 2018 Commonwealth Games. So we're one of the official partners for that. Generally like Las Vegas weather is, just occasionally a little bit more humid, sand and some surf, so more, really it's more like California I guess. A little bit about me, program director of this new program. We were the last university program to come online in Queensland and probably one of the last in Australia at this stage. We started in 2016 with our first cohort and it graduates in 2018. This is my 21st year working with the State Ambulance Service or Paramedic Service in IRCP language. And I started off as a volunteer and worked my way up to various executive roles, education roles, and then moved over into the university sector. I'm an active advanced care paramedic. I do that part-time in between running the course. But I'm also an active community paramedic as well. The things with those two roles is, depending which hat I have on, depends on what role and responsibility, drugs, etc. I get to play with. So I'm sure there's plenty of people in this room that have worn that hat before. And in previous services where I've worked with the military and private sectors, again, if I'm not wearing those hats, I can't use those skills in there. So I'm sure we've all had experiences in that life. Some of my research interests include the simulation and interprofessional learning, which is what we're talking about today, and also internationalisation of paramedic education and services, which is something that we're talking about later on this week. So, just a little bit about our program. As you can see, its development started in 2014. 15, the CAA gave us our initial approval. 2016, we moved into our first cohort. They graduate mid-2018. And something very new for Australia too is our national registration starts around the middle of 2018. So we're moving across that national body. And David, head of the CAA, he would have a bit of information about that too. So if you want to know what Australia's been doing in that space, there's a few of us here that can let you know. So how does our program work? Well, this is our program. Every university in Australia has its own program. Fundamentally, we're all teaching the same thing, how to become paramedics. Our paramedics don't come out work ready. They go on to a year-long internship to contextualise the training they do at university, and then they're let loose as a fully independent advanced care paramedic. So for our students, their first year is all foundational. So basic skills, basic assessment. Assessing, how do I assess a conscious patient? And then the second half is how do I assess an unconscious patient? So the foundational skills they need to become good higher level clinicians. From there, it's where the rubber hits the road. We get a little bit more advanced. We're going into our advanced ECG recognition. We're thrombolysing patients. We're redirecting people to PCI labs. We're going to advanced trauma education. We're doing other things like that. And then into our third year is where more all about our reflection, future direction of paramedicine, capstone, looking at alternate pathways and where you can manage and transport and things like that. And then finally, and that is actually covered in 2.5 years. So at the middle part of year 3 is when our guys graduate. Their fourth year, which would be the half of the third and half of the fourth, is where they move into that grad year. And that's that internship I spoke about earlier, where they go out, put it all together, and from there, once they successfully graduate from that, then they can continue on as an independent advanced care paramedic. So what I'm really about today is talking about how we incorporate our associated interprofessional learning within the health group. Now, the health group is the big group within this university that I work for that covers all the multidisciplines, be it paramedicine, medicine, nursing, other allied health services. Our paramedicine school is actually inside a medical education school, which is rare in the other paramedic education schools in Australia. There's not many of us that operate inside a medical school. The differences depends on which approach you take, but for us, our main difference is the fact that we do a lot of interprofessional learning and case-based learning. And if there's any other educators in this room, you'll understand just how much money that actually costs. But being in a medical school, it's how they promote their training, so we were able to help embrace that and really provide that more authentic style of educational experience. So the way our health group works with our training is we have our paramedicine group at the front. So your initial call out, what you get dispatched to, the whole pre-hospital experience, that's what we actually are doing with our students and with this program. But paramedicine education doesn't end there. It's all very great that we incorporate this little training inside a room or in an immersive ambient simulator that we'll see a little bit later. But what process happens from there? Well, with our students, we then take that initial scenario, so to speak. So let's pick a particular patient. Our paramedicine students pick their bit, and then from there, we go in and we deal with the nurses. This is where interprofessional learning starts to come within a university environment. They do their ER or ED, emergency department triage, hospital handover, and they continue that hospital journey up to that point. From there, we then move into our medical stool. So our future doctives, our definitive care. So then the paramedics working with the nursing students then do their handover to the future doctors that are going to be working in Australia. And from there, once the doctors do their bit, it then moves over to the allied health side of stuff. And that's our sort of, our interprofessional learning pathway that our students do. And you can see that it goes through multiple directions. So just looking at the paramedicine area to start with, we'll just flick this quick video, just give you a bit of an idea of what they actually do.
We're integrated inside the School of Medicine, which opens up tremendous opportunities for interprofessional learning, the simulation like you see behind us, just providing more of a hands-on, authentic training experience, which is what we're trying to get with all our graduates.
We get to use real-world equipment that we would use on road with QAS. Like, it's all the same stuff, exactly the same as on road.
We cap all our cohorts at 50. So enabling our sessionals and our lecturers to be able to spend more time with our students with the really advanced skills involved in this medicine degree now.
The quality of the paramedics that come in and teach us and lecture to us, it's really high and we learn a lot from them. So being taught to be more of an international scope of practice rather than just a statewide scope of practice, which will really benefit us when we look for jobs.
So that was the simulator that Gary was talking about before. That's the immersive ambulance simulator. There's a speech on that. Previously, we're talking about bringing ambulance units inside the classroom. So that's set up on hydraulics, which aren't turned on just yet. I'm still waiting to get the funding for that because that's the most expensive part of the simulator. But what you could actually see with those windows there, they're actually computerised TV screens which emulate movement when you're transporting. And with all the doors shut, the screens running, the students get that complete immersive feel that they're actually in a moving ambulance, to the point where we've had people end up with motion sickness and vomit throughout an ambulance, so it gives it that more authentic smell. And people actually grab onto things and balance themselves when they get to go up, even doing CPR and things like that. So that even without the hydraulics put on, and our hydraulic motion that we're looking at doing is basically forward movement, backward movement, and just the occasional jolt, so they get that more authentic realism. Now that setup itself has started to be implemented already in Australia. Ambulance Victoria have just introduced a level 1 section of it, so they don't have the screen set up yet and they don't have the hydraulics. But this is the actual environment itself. It can be, that version was a prototype, so there was a bit of expense involved in that because we didn't really know what we were doing. However, since creating that, we've identified key ways of doing it from both a cost-effective way as well as a more simplistic way. So for example, ambulance services here that operate modules on the back of your ambulance, you could actually detach one of those when they've reached their use-by date, convert it slightly interior if you've updated your change, and you could actually do a similar process. So there are simple ways you can actually adapt some of that training. You don't need to spend hundreds of thousands of dollars. You can actually use equipment that's already there instead of completely reinventing the wheel and reinvest some money that way. So from there, we move into our caring with nursing. So how do we integrate with the nursing, School of Nursing? So for us, the initial patient handover begins. And that's where the students learn their communication skills and learn how to talk to people. When I started 21 years ago, I was young. I still look young, I know. But back then, the average age was about 25. Now the average age is about 18 or 19. And in the current technology generation, they really know how to communicate well with Facebook and Messenger and Snapchat, but they don't know how to talk to people. They don't know how to assess people. So we do a significant amount of communication, education and training, to the point where the course that we have implemented in the course, if they fail it, we kick them out. If you can't talk to people, you can't treat people. That's pretty much a blanket rule. So far, we haven't had any students fail that particular course, and from as much as they go in kicking and screaming, why do I need to learn how to talk to people, while they're standing there talking on their phone to you, once they've done their first clinical placement, they understand the importance of what that course actually gave them. And then from there, moving through clarification of signs and symptoms. So for the nursing students that are learning how to manage pre-hospital patients and the paramedic students learning how to communicate what they've done with their pre-hospital patients, they can learn how to talk. And both nursing educators and paramedic educators then work together to debrief and explain whether positives, negatives, improvements, etc., etc. And then from there, the nursing students complete their documentation, which then moves on to the paramedics using their EPCR. So we've adopted an actual industry standard EPCR that was developed by Beyond Lucid Technologies. Jonathan's sitting up the back of the room there somewhere. And we actually get our students to actually utilise that. So it's sort of like we look at the initial patient treatment as the first stage, and then you do your transportation, you get to your hospital, you've sort of delivered your drugs, you've come up with your provisional diagnosis, and generally speaking, that's sort of where education stops. So what we've done is complete the circle to where the students will complete the complete EPCR. So that's the whole patient care journey. So they've handed over the patient, they've done their treatment, here's the EPCR, that's the scenario completed at our level. But then that scenario moves on from the nursing and the handovers to then moving on to the medical school. So that same patient then moves on to the medical students who then go through their various aspects of training where they do their triage handover, hospital management, etc., etc. So these medical students actually then spend a week in this simulated type mode with this patient, and they're on call, they're working in the ward, all that type of stuff. And sometimes they have the patient then gets sent home, and then the paramedic students are engaged again because there's been complications with the discharge. Okay, same patient, new case, new role, we go through the process again. So trying to add that authenticity to what we're actually trying to prepare them for when they graduate. And then from that process, we move into the allied health and other health services that are available. And we have teams associated. And this gives you a fair indication of the other areas within the health group that get involved. So this is a whole of health, a really holistic approach to education. Now, though our program is quite new and we haven't quite launched any of our postgraduate space, which is where the community paramedicine and in the levels of Australia, that's sort of like our intensive care paramedics, our low acuity response, helicopter flight paramedics, that type of stuff. That's where that sort of sits. So as Gary mentioned, in the language that we have in IRCP, the community paramedicine has all those different subgroups. Well, part of that subgroup in that more community paramedicine approach is to actually then engage so that we have referral services to things such as nutrition, dietetics, mental health, fall prevention, other things like that. So that's where we're going to venture in that space in the postgraduate area later on. And towards the end of our degree, we have a course that introduces the concepts of low acuity patient management and redirection opportunities. But again, we only spend a small time on that because the view we've put towards that is community paramedicine in the form like we've been discussing today and throughout this course. It's all very well providing the education to people on what to do at that sort of higher level, but without that clinical on-road experience and exposure to what these patients look like, you're really setting those type of people up to fail. So it's more orientating them with what they can do, how they can call for help, or whether they need to redirect in a different direction. But the whole purpose of this group here in that bigger scenario is that same patient, and then where do they go to those different areas, and what happens if they then need to be redirected. So this is the simulator that you saw the video of before. So as you can see, these are the windows that I mentioned before that all come alive. And once all the doors and everything are enclosed, it really brings it to its own. So the other thing we try to do with our rooms, as well as trying to work inside a simulator, because you can imagine everyone, when they're learning how to cannulate or do certain techniques for the first time, we have like tables set up like this, big bits of carpet, big areas of floor. You've got heaps of room to work in. Okay, so the patient suddenly goes into cardiac arrest in the back of that. Now show me how you're going to push the tables and the chairs out of the way. Show me how you're going to cannulate the left arm because the right arm's got something else in it that stops you from cannulating. Okay, so it makes them think outside. The paramedics in the room, how many of you have been to that case where you've walked in at 3 in the morning and there's blood or diarrhea all over the floor of the toilet? And you've got to try and perform. I mean, what do you do there? I mean, I've seen students start performing stuff inside the little toilet cubicle, but those thinking outside the box will drag them out of that little area to a space where you can actually work. And if there's sort of tunnel vision, they don't know that until they've shown, okay? And I think the beauty of simulation incorporated into your education and training is you can put them in environments that can help them remember later on in life. So other areas we're looking at doing is, and I know some universities in Australia have done this already, is we're looking at providing a more immersive environment. So it's all very well being in a room like this, but there's nothing authentic about it. So we've got cameras set up around the walls, so we can simulate them being inside a pool, or we can simulate them being beside a railway track, things like that. Simulate the shadow of the sun by having a camera coming down on the floor to emulate the ground that they're walking on. So little things like that to try and increase their real-world experience when we're working with them. Okay, so this is another example. This is actually a screenshot of the EPCR that we're actually using that's MedView from Bologna Technologies. So that's what the students will then fill out. So at the end of their scenarios, we get them to fill these out, hand them over. Most recently, They completed their second year respiratory assessments, where they went in as teams to do a respiratory assessment on a patient, be it asthmatic, anaphylactic, COPD, a couple of paediatric cases. They were randomly picked. And then once they completed that OSCE scenario, that end of semester assessment, they then had to complete this for their patient and then hand that in. And that was the end. That's how we ended that particular assessment for each student. Telemetry. So the monitors that we use Core Pulse 3 monitors, and we're looking at other avenues that are a bit cheaper than a $50,000 defibrillator used for training. But the beauty of that, along with our ePCRs, is we actually have used, and working in a Wi-Fi network within a university, we have the ability to start introducing the students to future technology. We're going to send that ECG up to the medical students or the emergency department as they're bringing that simulated patient in. We're going to send that ePCR up to them as well, so that when they're receiving the handover of that patient, they've already got a bit of an idea of what's happened with the patient, what's been done treatment-wise, and what to expect as they walk through the door. Now, I'm not sure if there's too many services. I know some have started to trial it in Australia in particular, but we're trying to provide that next generation of what's going to happen with our care. We aim our program to try and get students to graduate at what paramedics are doing when they graduate. So we're trying to get our students ready for when they graduate in 2018. And there's something big happens between when they start to when they graduate. What do we need to do to recontextualise our program so they're on board and they're graduating at the same level as what they're walking out to, not graduating with something that we haven't done years ago. Telecommunications, radio communications. Again, we start to introduce it through the first year of their program, but from year 2 and year 3 onwards, requiring same use of radios as everyone else. So radioing the sit reps. If they need to consult outside of their scope, or they need to consult to actually give something indifferent, we have them actually ring up on telephones. And we have real paramedics that work on the consult line, and the occasional doctors too that work in our medical school that participate on that. Now, they know what the students are going to ask for, and they actually emulate the same process. So we really engage that whole authenticity of them actually working on road. So we also do a fair bit of agency collaboration. Being a small university cohort size, it does enable us to actually collaborate quite closely with our neighbours and real agencies. So doing things with the Queensland Ambulance Service. So they're working with us at the moment using the simulator. They like that for their high acuity response community paramedics. So these are people that go in there and they do thoracotomies and all types of crazy stuff. So kind of like from HEMS level helicopters and all that type of stuff. So they do really high, and they're looking at utilising this kind of space along with, because it's right across the road from the main hospital on the Gold Coast, and really engaging some of our immersive techniques to help develop and train their highest level critical care or community paramedics in Queensland. And we also collaborate quite closely with the Queensland Fire and Rescue Service. So having our students work in conjunction with the fire recruits so that the fire recruits and the paramedic students can all start to get together and work closely with each other. One of the best things that ever happened in relation to mannequin design and updates with technology was the fact that they made them wireless. Yes, that presents its own set of issues, which I'm sure everyone's encountered over the years with Bluetooth dropping out and things like that. But it is far better than a fire service's jaws of life coming along and chopping your communication cable between your mannequin and your little response thing. The amount of those things I've had chopped up over the years, and the look on the face of the fire, what? So I know all they need to do is put the wet stuff on the hot stuff. So I mean, things like that are a little bit hard. But I love working with them. They cut me out of cars. It's all right. But we try to instill that. So working with the fire instructors, we encourage them, if the students are doing quite well in what they're doing, concepts grabbed, they're moving forward, we look at ways of increasing the technicality of them so that they can experience what it's like. What is it like? And see, I'm quite short. So I was always the one that got shoved in a car when it was upside down and it had to be cut apart. What is it like to have windows explode around you? Okay? What is it like to have someone in close proximity screaming at you, telling you to get them out of the car and trying to get them to calm down? Okay, so we try, with the smaller numbers, we're able to incorporate that kind of training and technology. Okay, so that's pretty much me. I know I was your barrier between lunch and getting fed, so I hope I haven't delayed your hunger and drinking it too much. Thankfully, I'm not the last person like I originally was, because I would have been your barrier between alcohol and dinner, so that would have been even worse. Yeah, any questions? Yes?
Do you use the military simulation for some of the military simulation models for your explosions and things like that?
Not yet. I have been working in collaboration with Nogra Barracks, which is one of our bigger barracks up in Queensland, and they've got an awesome simulator up in there that they use for some of their training. It's one of the bases before they go over to Afghanistan at the moment. So we are trying to work in conjunction with them, but that presents a whole nother gamut of hurdles as well. That one at the moment, no. Yeah. No, it would be a bit expensive to make mobile. But it's a great idea. It was thought of. Yes, sir.
I think you said that they 2.5 years into the program when they go out on the road.
Yes.
And really good simulation stuff. Do they get any experience of real-time ambulance work in that first 2.5 years?
Yes. So at the end of their first year, they go out on their first clinical placement. And that's 6 weeks, full-time, day, night, afternoon shift, fully operational. It is unpaid, as with most clinical placements around here. But within that, what we're trying to now implement, now that Queensland Ambulance has got this low acuity community paramedic approach, because first year is all about basic assessment of a conscious and unconscious patient, we try to get them to spend a couple of weeks in that operational period on road with those low acuity officers so that they can see what it's like to actually spend time at a patient. So my average time on scene in a low acuity role would be about an hour minimum, because I go through that full gamut of patient assessment. Our low acuity response that we do in Queensland, again, as Susan said, no community paramedic program is the same. You've seen one, okay? So ours is a little bit different. So we then look at going through, like, if you've met your general practitioner or your local doctor, we go through that kind of level of assessment with them. And in my experience on the jobs that I have done, let's say I see 10 patients a day, maybe 2 of them will end up in an emergency triage department. The rest may end up in a medical centre or redirected or deferred somewhere else. So the beauty of sending the first year students out with those people is they learn how to actually do these assessments, like these very, very concise patient assessments. And then the second year students, they're generally associated with all their operational on-road stuff as well. So, and they do approximately 240 hours in total, and we're in the process of also incorporating our hospital-based assessments, which will include time in the emergency department, time in day surgery so they can get used to shoving things down unconscious people's throats. Being a medical university teaching hospital, those poor patients don't get a choice. And then we look at people like CCU or ICU, where they can get used to doing other key intensive aspects as well. Yes, sir.
Hi, Kev Armstrong from Edgeley University. I quite like the interprofessional aspect. Our university will currently exploring the medical school as part of the health programmes. Can I ask you, did you although you said you're part of the medical school anyway, the paramedic programme set within that?
Yes.
Have you experienced any barriers with the other professions from paramedics moving through nursing and the interprofessional aspect?
No, quite the opposite. In fact, before the program even got up and running, and I attended the first interprofessional meeting of the entire school, if anything, it was, when can you start? And I used the term quite loosely to start with, saying, well, yes, we start with our first cohort in 2016, but in the grand scheme of things on skill set and knowledge, the students are basically useless. I said we need to wait till about the end of 2017, early 2018. They've had clinical placement experience. They've had knowledge and been able to apply what they've learnt so that they can actually provide some value-added process to the simulation, because there's no point providing someone that's simulating a paramedic that has no clue how to be a paramedic. Before we came on board, they actually used to get volunteers of actual paramedics that would come in. But with the introduction of our program, it's much more value added for both our students, nursing students and medical students to actually do that process themselves instead of actors pretending to be a set piece of that role.
Do you have combined learning objectives, or do you have a mixture of both for different professions?
Initially, the learning objectives would be set for the pre-hospital stuff would be very, very paramedic specific. But then when they move to the handover process, then you have your mixed learning objectives that nursing and paramedicine will put together. And to some extent, when we work with the medical students, particularly from the consult perspective, we then have joint learning objectives associated with that as well. Good?
We're going to pause for just a second. We have